I am Armand Mekontso Dessap, and I work in the intensive care unit of Henri Mandor Hospital in Créteil, France. We are going to discuss now the myocardial ischemia during ventilator weaning. I have no conflict of interest to declare for this presentation. As you know, spontaneous ventilation can be considered as an exercise. As you can see in these animal studies, when the minute ventilation increases in these models of shock, there is a huge increase in the cardiac blood flow, especially towards the respiratory muscles. And we can have a concomitant decrease in the blood flow in other sectors, leading to some degree of tissue hypoxia. During human ventilator weaning, there has been proofs of increased sympathetic tone. As you can see in this study, they evidenced an increase in the plasma concentration of norepinephrine and epinephrine in humans undergoing weaning. The consequences of this increased sympathetic tone can be a vasoconstriction leading to increased preload, but also tachycardia with alteration of diastole, and because of tachycardia, an increase in the oxygen consumption of the heart. And this increased demand of oxygen in the heart has to be compensated by an increased supply. But in this situation, precisely the supply can be diminished because of hypoxemia, tachycardia, and also decreased coronary perfusion due to the reduction in duration of diastole. And this imbalance may lead to myocardial ischemia, especially in patients with chronic ischemic heart disease. And this myocardial ischemia, which is called WiCI for weaning-induced cardiac ischemia, may contribute to WiPO, which is weaning-induced pulmonary edema, via the systolic dysfunction or the diastolic dysfunction it can cause. And you know that the other factors contributing to WiPO can be hypervolemia, which is frequent in patients in critical care, and also the ventricular coupling, especially in patients with COPD. When trying to scrutinize the mechanism of WiPO, you can see that in some patients, there is an increase in pressure. Here in the y-axis, you have the pulmonary arterial occlusion pressure, but we no change in the ventricular volume, suggesting a mainly diastolic mechanisms. But in other patients, you will have a concomitant increase in pressures and volume, suggesting a systolic mechanisms. Grasso suggested that in those patients with a systolic mechanism, probably the ischemic dysfunction is taking place here with changes in EKG patterns, and also some degree in dyskinesia when looking with echocardiography. Obviously, there are many reports of WiCI in the literature, but many of these studies used all the tools to assess the ischemia, especially 2-lead EKG for ST segment analysis. And you can see that the only study which used 12-lead EKG involved a very low number of patients. Recently, we performed a multi-center cohort study to assess myocardial ischemia during ventilator weaning in a total of 177 patients. For the definition of weaning-induced pulmonary edema, we used the tools proposed in the literature, including transthoracic echocardiography, the change in natriuretic peptides, and the change in proteinemia during the spontaneous breathing trial. As you know, Bushra and colleagues have proposed that when using TTE, we can assess the E to A ratio and the E to E prime ratio at the mitral level. And if these ratios are elevated, it can be used to detect patients with increased pulmonary artery occlusion pressure, so patients with WiPO during ventilator weaning. The use of natriuretic peptides was suggested by Grasso and colleagues. These authors demonstrated that during weaning induced pulmonary edema, there is an increase in the plasma concentration of NT-proBNP, which is not seen in patients with weaning failure, which is not due to a WiPO. And the increase in proteinemia was suggested by a French study. Here you can see that in patients with WiPO, there is an increase in the plasma protein concentration due to the filtration of the plasma from the vascular compartment to the alveolar compartment. So we use these three definitions with a liberal definition of WiPO when at least one criterion was present, and the conservative definition of WiPO involved the presence of at least two criteria. For WiCI, we use ST monitoring on 12 derivations. You know that it is a powerful tool to assess myocardial ischemia. In this clinical case, for example, you can see a patient during difficult weaning with a depression of ST in V4, V5, and V6, and the coronary angiography showed a significant stenosis of the lateral coronary artery, which was dilated. And you can see here after angioplasty that the weaning is a success and there is no change in ST segment in these leads. For the definition of ST changes, we use the European Society of Cardiology definition of 2012 for ST elevation or depression, but also the American Heart Association definition of 2013 for exercise testing. And with this definition, we found that the prevalence of WiPO was important during weaning. You can see that it ranges from around 50 to 60% using a liberal definition to around 20% using a conservative definition. Concerning WiCI, the prevalence is lower, around 20% with a liberal definition and less than 10% with a conservative definition. And you can see also in this graph that the intrication between WiPO and WiCI is not massive, and only a minority of patients with WiPO also have WiCI. Looking at the risk factors for WiCI, we found that chronic ischemic heart disease was not different between patients with WiCI and those without WiCI. On the contrary, intubation for cardiac arrest was more frequent in patients with WiCI as compared to those without, suggesting that probably occult ischemic heart disease is a risk factor for WiCI as compared to known ischemic heart disease. Concerning the outcomes, WiPO had a significant impact on immediate weaning outcomes. As you can see here, WiPO was more prevalent in patients with spontaneous breathing failure as compared to those with spontaneous breathing success, whatever the definition of WiPO we used. However, the impact on long-term weaning outcomes, for example, simple versus difficult versus prolonged weaning, as defined by the WIND definition, was not significant, as you can see on the right graph here. WiCI had no impact on immediate weaning outcomes. However, the prevalence of WiCI using the EHA definition was higher in patients with difficult and prolonged weaning as compared to those with simple weaning when we used the WIND definition. We tried to assess whether troponin was a biomarker of WiCI. Unfortunately, it is not. You can see that the plasma concentration of troponin do not significantly change between the beginning and the end of spontaneous breathing trial in patients with weaning. This is probably due to the half-life time of this biomarker, which is too long for such a use. Maybe myoglobin could be a better candidate for such an assessment. Some authors have suggested that ischemic mitral regurgitation may be a mediator of cardiac edema during acute ischemic heart disease, but in our cohort, we found only 17 patients with a significant mitral regurgitation at the end of the spontaneous breathing trial, and the majority of these regurgitations were mild, and only 3 were moderate, and none was severe. Concerning the management of WiCI, only 9 patients underwent an invasive coronary exploration, who found that 3 patients had significant coronary artery disease, but only 1 patient underwent angioplasty, and you can see that the majority of treated patients had a medical treatment. So in conclusion, the cardiovascular system is frequently implicated in difficult weaning. The mechanisms are complex, intricate. WiCI can occur in 10 to 20% of patients during weaning, but its intrication with WiPO seems moderate. Thank you for your attention.